And I always say this, ultrasound is part of the primary survey in shock. I like to adopt and think about shock kind of the same way we think about trauma patients. When you show up, that first information you get, the ABCs, history, physical, primary survey, point of care ultrasound is part of that primary survey in your patients with shock, just like it is in trauma, whole nother topic. And again, we talked about this. First, recognize that the patient's in shock, do a history and physical guided point of care ultrasound, characterize their physiology, and if possible, identify the etiology of their shock directly. And the 4 questions, and I'm going to beat this to death, so I want to help you kind of get a grasp of this. You really only have to answer these 4 simple questions. 2 about physiology. Is it obstructive or is it cardiogenic? And then from an etiology perspective, is there a source of hemorrhage or a source of infection? And that's what we're going to look for. And we'll break that down a little further. Here's the exam. Again, heart, IVC always. And then depending if they have respiratory symptoms or not, we're always going to do pretty much most of the abdomen and the lungs. But the order just changes depending on respiratory symptoms or not. So the heart's the money shot, right? The heart's going to tell us about their physiology, tell us a ton of information, and a lot of times it may lead to a direct diagnosis or an actionable diagnosis. So that's, in many of these patients, going to be the most important thing you do is look at their heart. And if for some reason you couldn't look at anything else, someone said you got to pick one organ to look at, the heart is where you want to look. Now, this is not necessarily related to ultrasound, but I do like to point out, especially, and I talk about this a lot when I'm teaching residents, is to beware of compensated shock. A lot of us associate hypotension with shock. If we see hypotension, there's a good likelihood that patient's in shock, but we often will see patients who have compensated shock, that maybe they were hypotensive before they came, or maybe they're still compensating. But remember, shock is a mismatch between tissue perfusion and tissue metabolic demand. And patients may have a normal blood pressure and may still be in shock. And most of the time, that's going to show up with signs of end organ dysfunction, and often one of the most common findings we may see is kind of confusion or altered mental status, somnolence. Those all may be signs of compensated shock. Things like fatigue, confusion, poor feeding, syncope may be a sign of shock. Maybe it was transient, or maybe it's now compensated. When you see them and they're lying flat, maybe they've received fluids before they got to you, and now they're compensated, or they look improved. And we all know that the stakes are high in patients with shock. There's not a lot of margin for error, especially in the very beginning when they first show up, or before the diagnosis is fully known or fully grasped. If you don't make good decisions, bad things can happen. This is why point-of-care ultrasound is perfectly suited for this application, because people in shock, we need to make accurate, rapid decisions. We need to make decisions with as little information as possible, and point-of-care ultrasound is suited perfectly for this. Now, we're going to talk about physiology, not because I want to get into tons of physiology. This is not a physiology lecture, but we're going to talk about the physiology of shock and how we match some of the ultrasound applications and findings to these physiologies. And this is the way I think about shock. This is very medical student level breakdown of physiology, but we have our cardiogenic, our hypovolemic, and or hemorrhagic, and we have obstructive and distributive. And sometimes I like to leave this endocrine on here as a reminder to get a TSH and a cortisol level and things like that. Not that there's a pure endocrine-only physiology of shock, because it tends to be a kind of a mixed picture. So that's why I keep that one on there. And so just breaking these down a little bit more, so cardiogenic, this is usually going to be pump failure, but we can't forget about the mechanical causes. And then the hypovolemic or hemorrhagic. The hemorrhagic is the one I don't want to miss, and just don't forget that people hemorrhage for reasons other than trauma. Blood loss, bleeding of the abdomen or chest, GI losses, GI bleeding, ruptured AAA. And remember, they may be, if they're, depending on the stage of their shock, they may not be in a state to tell you about their flank pain or back pain from the AAA. And of course, fluid losses, which we may not directly see with ultrasound. Then we've got our obstructive things, cardiac tamponade, PE, tension pneumothorax. We're not going to talk about it much, but you could talk about abdominal compartment syndrome. You could go on and on. We're not, obviously, this is not completely comprehensive, but these are the most prevalent and most common things. Our distributives are anaphylactic, neurogenic, and then classic descriptions of septic shock, although we know often there can be some mixed physiology with septic shock and some cardiac involvement. Then endocrine, from a physiologic perspective, often is a mix of some of these. So I highlight these in red because these are all things we can directly diagnose with ultrasound, and most of them by looking at the heart and maybe a little bit in the chest. or the abdomen. So we will look and we will directly make these diagnoses: pump failure, mechanical etiologies of shock. If they're bleeding from a AAA or there's blood in their abdomen, we should be able to identify that. Tamponade. Any PE that's significant enough to cause shock should be a massive PE by definition, so we should see signs of that on echocardiogram. That does not mean we can rule out PE with point-of-care ultrasound, but it means large PEs, massive PEs, significant enough to cause shock and respiratory failure, we should see signs of on ultrasound. And then tension pneumothorax. Again, you probably would have some other clinical things that might make you think this, but ultrasound can help us make this diagnosis directly. So I like to highlight those because right there, if you look for these and you find these or you cross these off, your differential just got a lot shorter and your job just got a lot easier. The weight on your brain just got a lot lighter. Now, taking a look at these different physiologies of shock and breaking down some of the ultrasound findings. And we're going to go through these in a little bit of detail. So in cardiogenic shock, most of the time what we're going to see is poor left ventricular function, right? Because most of the time it's going to be pump failure. But we can't forget about these mechanical findings. And we'll review these a little bit. And I'm not here to say that you need to memorize every exact finding of every one of these, but just don't forget to keep these on your list, because if you don't have them set in your mind, you're going to forget about them. And then with hypovolemic and hemorrhagic shock, if the patient otherwise has baseline pretty normal physiology, they should have a vigorous looking heart, probably hyperdynamic, and usually they're going to have a collapsing IVC. Now, this does not take into account people with kind of underlying cardiopulmonary disease that may have an effect on these, but in our baseline normal physiologic patients, these are the things we should see: a vigorous heart and a collapsing IVC. And if they have hypovolemic or hemorrhagic shock, and that's what we think based on what we've seen with their heart and their IVC and their physiology, then we're going to start looking for etiologies. We'll get to that later. Obstructive shock, this is typically going to be things like cardiac tamponade. We're going to see signs of RV strain and a massive PE, or we may see signs of a pneumothorax, and presumptively that's a tension pneumothorax if it's causing shock. Again, direct things we can directly see with point-of-care ultrasound. Now I want you to notice distributive shock. Again, assuming a baseline pretty normal physiologic patient, they should have a vigorous heart and a collapsing IVC. So notice it's kind of the same physiologic picture as hypovolemic or hemorrhagic shock. So let's just highlight those for a second and talk about those. So our distributive shock, that's going to be anaphylaxis or spinal shock, or kind of our classic descriptions of sepsis. This is also kind of what happens when you go under general anesthesia, right? So hopefully we have some other clinical clues, right? Like they're red and itchy, had a very sudden onset, or an exposure to an offending agent to help us with our anaphylaxis. Spinal shock, probably going to be in some sort of trauma with other kind of neurologic findings. Now, classic sepsis, maybe there are not a lot of other findings, so that's going to be on our list. And then for hypovolemic or hemorrhagic shock, as we continue with our point-of-care ultrasound, we're going to look for some of these other etiologies, like an occult ruptured AAA. And really, we're just going to see the AAA and try to decide, do we think that that's an etiology or not? Or maybe we see intra-abdominal blood from a spontaneous spleen rupture, a ruptured mesenteric aneurysm of some sort, or other etiologies. With the ultrasound findings of a vigorous heart and a collapsing IVC, as we continue, again, incorporating clinical information and continue our ultrasound and continuing our sonographic investigation, we should be able to delineate this further. And then looking at cardiogenic shock, we're going to talk first a little bit about some of the mechanical findings. Most of these are going to involve some kind of acute regurgitation, maybe from aortic dissection, where you might get acute aortic regurgitation. In my patient population, endocarditis is probably the most common thing. Papillary muscle rupture may also be on the list, so complications of MIs, which could include an ischemic VSD or an LV free wall rupture. Now, some of these things are going to be pretty obvious and relatively easy to identify, and some of them may not be. Now, one thing that they're generally going to have in common is most of these patients are going to have sonographic B lines when you go to look at their lungs. This is why performing a holistic exam of heart, lungs, abdomen, and any other suspicious or concerning areas is going to be paramount in all these patients to get a full physiologic picture. So remember, patients with mechanical cardiogenic shock are probably going to have sonographic B lines and signs of pulmonary edema. And as far as some of the other findings with cardiogenic shock, signs of pump failure and poor left ventricular function, and with obstructive shock, like we said, these are mostly direct ultrasound diagnoses: dilated right ventricle or cardiac tamponade, or maybe tension pneumothorax. And we'll look at some of those more specifically here shortly. And again, back to our simplified questions. From a physiologic perspective, is it obstructive, is it cardiogenic, or is there a cardiogenic component? If it's not those, or even if it is these, and we still don't think that's the complete picture, looking at an etiologic perspective, is there a source of hemorrhage or an identifiable source of infection? This is how we're going to approach this. If it's not obstructive or cardiogenic, probably what you're going to do is you're going to start this patient on fluids, and then you're going to do some more evaluation. And maybe you've then identified another source that there's hemorrhage or infection that you want to treat more directly.